Okay, we're going to be covering drugs affecting the autonomic nervous system. This first lecture is going to cover chapters 18 and 19, so we're talking more specifically about the fight or flight component of the autonomic nervous system. A quick reflection: you gain strength, courage, and confidence by every experience in which you really stop to look fear in the face. You are able to say to yourself, I have looked through this, I can take the next thing that comes along. You must do the thing you think you cannot do. With every challenge, you're going to find that when you come out on the other side, you come out much stronger and much more capable. So just a few words of encouragement. Okay, so like I said, the first chapter we're going to cover is going to be chapter 18, and we're talking about the adrenergic drug. Our objectives here is we're going to quickly describe the functions of the sympathetic nervous system and the specific effects it has on the body, list various drugs classified as adrenergic agonists, discuss the mechanism of action, therapeutic effects, indications, adverse and toxic effects of those drugs, and then kind of apply it to the nursing field. As a quick overview here, we've got the nervous system, and it's going to be broken down into two different parts, the central and the peripheral. Your central nervous system is essentially just your brain and spinal cord. We're not going to talk about that today. You'll cover that more so in pathophys. And then you have the flip side, the peripheral. The peripheral is broken to the autonomic and then the somatic, and your somatic is going to be your skeletal muscle. So you can think of it this way: the autonomic nervous system is going to be the portion of the nervous system you can't control, whereas a skeletal or somatic nervous system is going to be the portion of it you can control. You can control what your skeletal muscles do. That's how you get up and move around. For this lecture, we're going to ignore the somatic and focus in on the autonomic. Also, you can call it the automatic nervous system. Your autonomic is composed of both the parasympathetic and the sympathetic. Your parasympathetic is what the next lecture, chapters 20 and 21, is going to focus on. For the next two chapters, we're going to be speaking solely towards the sympathetic nervous system. Sometimes it's also called the adrenergic nervous system. Within this adrenergic system, there's going to be two types of receptors that we'll talk about, the alpha and the beta. Each receptor has two then subcategories, so there's alpha 1 and beta 1, alpha 2 and beta 2, and there's actually a beta 3. Of the receptors, though, most of our good comes from the alpha 1 and then beta 1 and beta 2. We really have very few uses for the alpha 2 and then the beta 3, which isn't on your screen. They exist, so they're presented, but they're not terribly useful for what we're going to do today. Another kind of side note, your parasympathetic is also sometimes referred to as the rest and digest system, whereas the sympathetic nervous system is going to be called the fight or flight, or referred to sometimes as the fight or flight system. So a lot of our drugs, when we're stimulating, we're trying to evoke that fight or flight response for some reason, and when we're antagonizing or stopping or blocking the sympathetic nervous system, we're stopping that fight or flight for whatever reason. So with the sympathetic nervous system, again, sometimes called the adrenergic nervous system, they're interchangeable terms, so don't let those kind of trip you up at all. We have the different receptors. There's alpha 1, and then there's the beta, which has 3, and then there's actually a third receptor that we're not going to get too terribly caught up in. Starting at the top of your outline, though, we've got our alpha, which is divided into two separate receptors. We've got alpha 1. Alpha 1 is largely located in the blood vessels, on the liver, and then in your GI tract, the muscles which control your GI tract. You might want to make a little comment there that I'm just talking about the gastrointestinal system, not the skeletal muscles. Also located on the bladder, reproductive organs, and then in the eyes. Now, the alpha 2 receptors, I said, don't have a ton of significance when it comes towards pharmacology. That's true in some aspects. For this class, we're going to say they don't have a lot of control. When you go on for an advanced degree, whether it be FNP, nurse anesthetist, then you're going to find that that's kind of a lie. We do use them, but it's at a higher advanced level than what you probably care to know right now. Alpha 2 receptors are located almost solely in the nerve terminals, specifically the presynaptic nerve terminal, And what they do is they control the release of neurotransmitters. So when you stimulate these, it actually increases the release of norepinephrine, epinephrine, dopamine. When you block these receptors, it kind of decreases that. Again, it's more of an advanced practice thing than what we're going to be too concerned about right now. And then moving on to the second category of receptors, we have the beta receptors. For this, there's 3 different ones. Beta 1 are largely located on the heart and in the kidneys. Beta 2 are also located on the blood vessels with alpha 1. You're going to see we have certain medications which act on the alpha 1 and beta 2 receptors, and they're all working on those blood vessels, trying to get them to constrict or dilate. Beta 2 is also located in the liver, the lungs, and the muscles. And then beta 3 is located in the adipose tissue. Again, we don't really use beta 3 for pharmacologic purposes, but it does exist, so there you know about it. The third type of receptor, which we're not going to get too hung up on today, but there is a third adrenergic receptor, it's the dopaminergic receptors. If those are stimulated, it increases blood flow, more specifically to the kidneys, GI system, heart, and brain. So it exists, but we use it slightly. I'll point it out with one of the medications, but it's nothing that you need to really stress about memorizing. Really focus on the alpha and the beta receptors, and I would highly suggest you kind of learn or memorize where they're at in the body, so that when you know a medication's working on alpha 1, you know it's on the blood vessel, livers, bladder, eyes, blah, 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 and then you'll be able to trace the side effects back to it without trying to blanket memorize everything that I tell you in this PowerPoint. So the functions of the receptors here, and I have this broken to a table for you so you can kind of see. Again, alpha 1 is located on the blood vessels, and when stimulated, it causes vasoconstriction. What that means for your body is it's going to increase the blood pressure. So we might give an alpha 1 agonist to bring the blood pressure up in, say, a shock situation. Or we might block the alpha 1 receptors to cause vasodilation, because if you block, you cause the opposite to happen, and then that brings the blood pressure down. The next location is on the liver, and there it, when stimulated, causes what we call glycogenesis. Glycogenesis is a mechanism where the liver releases stored glucose into the system. So in a healthy human being, and you or me, when our blood sugar falls low because we haven't ate for a while, the liver releases stored glucose to bring it back up so you don't go into hypoglycemia. Therefore, when you stimulate this receptor with a medication, it's also going to increase your blood glucose level because it's stimulating it to let go of that blood sugar and then brings your blood sugar back up. The next part is in the GI system, GI muscles. What it does when stimulated relaxes those smooth muscles. As they relax, it actually decreases the GI motility. And if you also think along this, like if you're stimulating a fight or flight, you'd want your blood pressure to increase and your heart rate to increase, so you're kind of amped up, ready to go. You want that energy in your system so that you can either run, use the energy for running, or use the energy to fight. And then also it's going to shunt blood away from the GI system, because we're not terribly concerned about when our next bowel movement is if we're running from somebody trying to attack us. So it shunts blood away from the GI system, causes decreased GI motility. The next thing is the constriction of the bladder from the alpha receptors located on the bladder. Now when somebody scares you, you might pee your pants. It's the same thing here. It causes contraction of the bladder, which can sometimes result in unintentional urination, also known as incontinence. So if you just think about when you get scared, or if you ever scare somebody and they pee, that would be why. The next one is the dilation of pupils for the receptors located on the eyes. With this, so when your body stimulates the sympathetic nervous system, it causes your eyes to dilate, and the purpose of that is to allow more light into your eyes to allow better vision. So if you're running at night, it kind of opens it up so you can see a little bit better. What this means for drugs which stimulate that is they might complain of sensitivity to light, or photosensitive. Photophobia is another way to say it. And then the last one is there's an increase, actually this should be decreased function. For your repro organs, When you stimulate your sympathetic nervous system, it decreases the function of the reproductive organ, so actually it results in infertility, not babies. If you want to make that correction as I look at your outline, I see I screwed that up as well. It's just a suppression. And the increased function of the reproductive, we're not hitting repro medications today, so you don't really have to be concerned about that. I just included it in there because your book does too. But it actually inhibits reproductive organs. And then alpha-2, in those presynaptic nerve terminals, when stimulated, it increases the response of all the other receptors. So it just stimulates the response of the fight or flight. Moving on, and I've got the beta receptors divided into 1 and 2. For beta 1, when that's stimulated, it increases the contractility in the rate of the heart rate, or the rate of the heart. So when you increase contractility, that allows each time your heart pumps, more blood comes out. By increasing contractility, if you are really gearing up to run or to fight, what that would do is allow better oxygenation, which is going to increase your endurance. And then increased heart rate, if you ever get scared or if you've been startled, you'll know your heart naturally increases, so it also results in some tachycardia. And then for those receptors located on the kidneys. For those of you who have had pathophys, this layout is going to look really familiar. If you've not had pathophysiology, this might be a little bit foreign to you, so just bear with me while I explain it to you. There's two systems which control the blood pressure, the nervous system, which is a quick control, and then you have the endocrine system, which is more of a slow control. This angiotensin and renin is a substance that's secreted by your kidneys, and it's secreted in response to a low blood pressure. So when renin is secreted, what happens is your kidneys let it go, and it goes to this green angiotensin and converts it to angiotensin 1. And then angiotensin 1 gets converted to 2 by what we call ACE. And ACE stands for angiotensin converting enzyme. So ACE just takes 1 to 2. What happens once we get this substance in the body is you secrete aldosterone, which keeps extra water in your body, which boosts up your blood pressure, and sodium, which also increases your blood pressure. It also works on this ADH, and you can think of ADH as an antidiuretic hormone, is a better term than this here. So it also increases your antidiuretic hormone. If you've got a lot of antidiuretic, it's also going to cause your blood vessels to constrict and water to be retained. Angiotensin 2 is also a vasoconstrictor. What these three mechanisms mean is that it increases your blood pressure. So when the beta 1 receptors in the kidneys are stimulated, it releases renin, which then causes this chain reaction to occur, and your blood pressure increases. For beta 2, for those located on the blood vessels, causes just slight vasodilation, which would actually lower the blood pressure. It's kind of a weird mechanism, and it's more of a compensatory thing. I wouldn't get too hung up on it, just acknowledge that it's kind of weird to move on. Now what I do want you to look at is the beta 2 receptors located on the liver also induce glycogenesis, so it's going to release more blood glucose into the bloodstream and then result in an elevated blood glucose level or blood sugar level. Also, when stimulated, it results, the receptors on the lung result in bronchodilation. What this does is when you're getting ready to run or to fight, it opens up your lungs so you can get more air into your lungs, which then goes in more air into your blood system, your bloodstream, which then increases your endurance. We will use this bronchodilation effect to help our asthmatic patients breathe easier. So it increases the ease of breathing, or you could also say it increases ventilation, if you want to use a very technical term. And then on the muscles, same thing. It's shunting blood away from the GI system, so it results in kind of relaxation of the GI muscles, decreased GI motility for that. Keep in mind, this is when we stimulate all these receptors. Our next chapter is going to be the suppressing these receptors, so then we're just going to flip all these around and look at how we can use them in that way. For now, though, neurotransmitters for the sympathetic nervous system include epinephrine, norepinephrine, and dopamine. Now, all three of those we're actually going to talk about as drugs here in just a few minutes because we've been able to select them or isolate them in a lab and then turn them into a drug so then we can increase the sympathetic nervous system if we need to. So epinephrine, norepinephrine, and dopamine are both a neurotransmitter, and then we also use them as a drug. These neurotransmitters are broken down by two terms which should sound familiar because we talked about them when we talked about Parkinson's medications. The first one's the monoamine oxidase, the MAO, and we talked about MAOIs as being a medication, and that was a medication which just prevented the breakdown of monoamine oxidase. It's a monoamine oxidase inhibitor. What that does is just keeps more epinephrine, norepinephrine, and dopamine in the system. For Parkinson's disease, of course, we're trying to keep more dopamine in the system. And then the catechol orthomethyltransferase, also known as COMT, again, we talked about that as helping keep more dopamine in the system for your Parkinson's patients. So kind of keeping in line with keeping everything together there. Okay, more about the adrenergic drugs here. Adrenergic drugs, the term itself simply means they're stimulating or mimicking the sympathetic nervous system, and they might also be called a sympathetomimic, adrenergic agonist, or a beta agonist. All those terms are referring to an adrenergic drug. For this class, and because what it's typically called out in public or out in the field is an adrenergic agent, so typically that's the term I use. Although you will see me use beta agonist if I'm trying to point that we're only working on the beta receptors, or an alpha agonist if we're only working on the alpha receptors. But as a general term, I prefer the adrenergic agonist. Plus, it's easier for me to say. So there you have it. For the mechanism of action, it depends which receptor the drug is acting on. Essentially, they're all going to increase the sympathetic nervous system, but based on which receptor it's stimulating is going to kind of tell you what it does. This is also where knowing where the receptors are is going to help you a lot when you're trying to figure out side effects and indications. So when you stimulate the alpha receptors, that specifically results in vasoconstriction, which is going to increase the blood pressure, relaxation or shunting blood away from the GI system, contraction of the bladder, which might make you pee, and then dilation of the eyes, which can sometimes be used in an ophthalmologist's office if they need to do a dilated exam to look at the back of your eye. And then on the flip side, we have the beta receptors. And this, again, I've got broke down to 1 and 2. I don't do that with alpha just because we're really only concerned about alpha 1 for now. For beta 1, when stimulated, it causes a positive inotropic effect. What that means is there's an increased contraction of the heart. So sometimes we'll use a beta 1 agonist for heart failure to increase the contraction. It also causes a positive chronotropic effect, which increases the heart rate. And again, if you've been scared or ever scared somebody and their heart starts beating fast, that's also why they say not to send people with a heart condition through like a spook house or a haunted house, because if they get scared and their heart beats too fast and they can't handle it and they pass out, you don't want to be responsible for that. The last one, there's a positive bromotropic effect, and this just indicates that there's an increased conduction of electrical nerve impulses when beta receptors are stimulated. And then the next one is bronchodilation. Again, for the beta 2 cells in the lungs, causes bronchodilation. We use that frequently for patients who have asthma, and that also increases the glycogenesis within the system, so increases the blood sugar as well. For indications, I've got this broken down into the different systems. The first one is going to be the respiratory system, and what it's used for here is the bronchodilation component. It allows better ventilation, which again is just allowing more air into the lungs, increases exercise tolerance, makes it easier to breathe, all that jazz. The next indication would be a nasal decongestant, and it does this by two ways. One, it results in constriction of the nasal arterioles, so you have smaller blood vessels in the nasal arterioles, and then that reduces the nasal blood flow. As you reduce the blood flow to your nose, you're also shunting your immune system away from your nose. And a lot of your congestion is a result of an increased immune system. Like your histamine, if you think of allergies, that's all immune related. So if we can shunt the blood and the immune system away from the nose, it's going to help reduce congestion. Again, it's a stimulation of the sympathetic nervous system that allows us to do that. And then the last one is the cardiovascular indications. This is probably one of the most common indications for using these medications. What it does is it supports the cardiovascular system during a physiologic shock or also during heart failure. And they can be referred to by a couple different terms. All those terms mean the same thing, whether we're calling them a vasoactive, sympathetomimic, vasoconstrictive, inotropic, cardioselective sympathomimetics. They're all the same. I typically call them a vasoconstrictor because that's what they're doing, is they're constricting the blood vessels. But they all mean the same thing. So how it works to support cardiovascular function during a shock is it constricts the blood vessels. By constricting the blood vessels, you're going to increase the blood pressure. One of the things that happens during shock is your blood pressure bottoms out and your blood doesn't flow to many of your major organs. So like your kidneys get shut off, your brain can get shut off. As that blood pressure falls, you have decreased perfusion. Blood's not flowing where it should. So we'll give these medications that constrict those blood vessels, and what that does is then increases the blood pressure, so we start pushing blood to the organs which need blood to survive. The other thing that these medications do is it stimulates the heart. It increases both the force and then the rate of the heartbeat. So your heart beats faster and it beats more forcefully. As it beats more forcefully, more oxygenated blood is getting out into the system. And then as the heart beats faster, you're just increasing the rate of how quick it goes. Also acts to help increase oxygenation of the tissue and increase the blood pressure too. Some of your side effects here, and I've got this broken into common and then some of the cardiovascular ones that I want you to know, and then just some miscellaneous GI ones. As far as the common ones, these all result from the stimulation of the sympathetic nervous system, particularly the increase in norepinephrine of the system. So, norepinephrine is the neurotransmitter that causes the system to fire. It also is responsible for keeping you awake. So if you have increased norepinephrine or stimulated norepinephrine as a neurotransmitter, you're going to be more restless, going to be maybe a little bit easily excitable is what your book uses. I've also said that it makes people more like irritable, like they just can't relax. And then patients will also complain of insomnia because of that neurotransmitter norepinephrine's increased. So those are all perfectly common side effects. We know they're going to happen, and unfortunately there's not a whole lot we can do about it. And truly, when somebody's in a shock situation, we're not really concerned if they're having difficulty sleeping or not. Plus, a lot of these medications are only used in the intensive care unit, so we might give them, and then we will give them an anesthetic agent to put them into like a medically induced coma. So then they really don't care if they've got insomnia or not because they're not awake. So just keep that in mind as we're reading through these. Some of these we know they're going to happen, and given the severity of the situation, not to be cold-hearted, but we're not terribly concerned about it. The next one is going to be the cardiovascular effects. Because we're increasing the blood pressure, there is the potential to cause hypertension. So these medications are always monitored very closely because we don't want blood pressures in the 200s over 100s either. We don't want them in the low dumps of the 40s over 50s, but at the same shot, we don't want them too high. If you overdose these patients, they will, if you keep giving them the medication and not monitoring it, you do have that potential to increase their blood pressure too much. Also, same thing with tachycardia. We want the heart to beat a little bit faster, but we certainly don't want rates in the 150s. We really don't want rates greater than 120. And 120 would be a healthy person. Anytime the heart rate gets, not anytime, but as a rule of thumb for you, if the heart is beating faster than the low 100s, it probably should be slowed down. And that's for your healthy adult. Now, in infants, we want the heart to beat faster than that because there's a difference in their body. Again, too much of a good thing becomes a bad thing. It can also cause some dysrhythmias. GI system, we're not concerned if they're nauseated, if they're in a shock situation. We're just not. So it's going to happen. If they're awake, they might complain about it, but most of the time these patients are in a medically induced coma, so they don't even care if they're nauseated. On the flip side of the screen here, you're going to see I have just a few notes there. The first one's going to be management of toxicity. This would be a management of an overdose. So if you're not monitoring your patient, they get a little too much epinephrine and suddenly they have a high blood pressure. What we're going to do is our treatment's going to be supportive. We stop or decrease the epinephrine dose, and then we give an antihypertensive medication, which you're going to learn about later in the class. So just understand that first you're going to stop the medication, and then you're going to start treating whatever it is you caused by an overdose of that medication with antagonists to these to help bring it back down. So an antihypertensive. There's also certain drugs that we'll cover in the next chapter that bring the heart down, called a beta blocker. So they're going to be supportive when you overdose. As far as interactions, a lot of medications are either going to have the additive effect or the antagonist effect. If you refer back to some of the first notes that you listened to, the additive effect would just be increasing the effect of these medications. So anything that's stimulating the nervous system. We just talked about CNS stimulants, sometimes used for like ADHD, would interact with these drugs because it's going to add on to the effect. Also, many anticholinergic medications, which will be in the next recorded lecture, will increase the effect of these drugs. And then there's certain ones which will have an antagonist effect. Any sort of an antihypertensive, anti-tachycardia, many antidysrhythmic medications are going to decrease the effect of this drug. Again, if you overdose, that might be your goal of pushing an antagonist drug, but those would be all your interactions. Nothing you need to necessarily memorize, but I want to bring that to light, that that's kind of what would interact and that's what would antagonize it as well. So, moving on to the specific drugs. I have kind of quite a few here for you guys to know, but they're fairly similar and they're not too terribly complicated to learn. The first one is dobutamine, or Dopatrex. This is technically a vasoactive adrenergic drug. What that means is it's going to increase the cardiac output and it's going to increase the cardiac contractility. That is both going to increase blood pressure and keep perfusion to the tissue. So it's going to keep the blood flowing to all the tissues in the body when a patient undergoes a shock. Now, a shock situation, if you're not aware of it, can be caused by a couple different factors. It can either be an allergic reaction, an anaphylactic shock. It can be caused by loss of blood. It can be caused by an infection. It can be caused by heart failure. Regardless of the cause of shock, for the most part, the treatment's all the same. We got to get the blood flowing back to all the tissues we want to preserve function. And this is how we do is we grab a vasoactive drug. This particular dobutamine is an IV infusion only. It does not come in an oral medication, and you're going to see that's true for many of these drugs. The reason why it's IV only is we don't have time. If somebody's got a low blood pressure, we don't have time to give them a pill to wait for their blood pressure to come up. So you pop an IV in and then you start these infusions. Dobutamine itself is typically a continuous infusion, and it'll be again for patients in the intensive care unit who need constant monitoring. Pharmacokinetics, you can see here that it has an onset of action of less than 2 minutes, but then the duration of action is less than 10 minutes. So it acts really fast, but then it's done working really fast as well. That short duration of action is the reason why it's a continuous infusion. That would be the reason why you couldn't just push this and then stop. If you pushed it, say you just grabbed an IV push, gave them a dose of it, their blood pressure would come up for about 10 minutes and then it would go right back down into the low 40s over 30s or whatever it was. So that's why it's a continuous infusion, because of that short duration of action. So that's dobutamine. The next one is another one of the neurotransmitters turned drugs, and that would be dopamine, or inotropin. And you can remember the positive inotropic force that these drugs caused. Inotropic force, inotropin, it's a vasoactive adrenergic drug, stimulates it all, if that helps you remember. If not, don't stress about it too much. This is going to act in a couple different ways. One, it's going to dilate blood vessels, particularly to the brain, kidney, heart, and mesentery. It's going to increase the blood flow there and takes a very, very low dose of dopamine to do so. So if you give them just a low dose of it, that's what it's going to do. It's just going to dilate everything. Helps ease blood flow there, but it's probably not going to do much to the blood pressure. If you give a moderate dose, a middle of the road dose of dopamine, you're going to both dilate the blood vessels, but then also improve cardiac contractility, which is going to start improving perfusion. Then if you give a high dose of it, it's going to cause vasoconstriction, which is also further going to improve the blood pressure of a patient. So this is one that we'll give the dose based on how much good we need to do. Again, it's an IV only, continuous infusion only, because it's got a short duration of action. You can see the onset is just slightly longer than dobutamine. Otherwise, it's a pretty similar medication. The next drug we have is epinephrine or adrenaline. Epinephrine is another of those neurotransmitters turned into a medication. Now, this is what we call a non-selective adrenergic agonist, meaning epinephrine hits all these receptors. Because it's working on multiple receptors, like all 5 of the receptors, alpha 1, 2, beta 1, 2, 3, and then I guess also the dopamine receptors, it's going to cause the most side effects, and it's going to be the most potent medication we use here. Because it's a very potent medication, it tends to be really good for emergency situations. It gets us out of a pinch real quick. So you're going to see this used frequently for like people who have an allergic, if they know they're allergic to something. For example, people allergic to like bees will oftentimes carry an EpiPen with them. They can quick give this medication subcutaneous, and it restores function, reverses that anaphylactic shock. We will also use it in the ICU in an intravenous situation to help preserve function if the shock's been caused by like an infection or for something that we need a sustained release for this. At a low dose, what this does is increases the force of cardiac contraction, it increases the heart rate, and it also causes bronchodilation. Now, the bronchodilation is one thing that the dobutamine and dopamine is not going to cause. So that's why epinephrine becomes the choice for an anaphylactic shock. When somebody comes in contact with something they're allergic to, it closes off their airway, so therefore this just kind of reverses that, or it doesn't kind of, it does reverse it. At a higher dose, epinephrine also acts as a vasoconstrictor, which again brings up blood pressure and increases perfusion to the different tissues that might be lacking if a patient's got a low blood pressure. And then the side effects are going to be stuff we've already covered, hypertension, tachycardia, increased restlessness, but again, we're not terribly concerned about it because if we have to save your life, that just might be something that you have to live with for a few hours till it wears off. The next medication is another one of those neurotransmitters, norepinephrine, or Levophed. Norepinephrine is what I know it by. And this is going to be mostly an alpha adrenergic agonist. So epinephrine is acting on both alpha and beta. Norepinephrine is mostly just on the alpha. And the other specific thing to norepinephrine is it has zero effect on the lungs. So it is not going to stop the airway from closing off. If you give norepinephrine instead of epinephrine for an anaphylactic shock, your patient's going to die because it's not going to do anything you want it to. It's not going to have the right effect on it. Another fun fact about norepinephrine is it's metabolized to dopamine in the liver, so then it will also help dilate some of the blood vessels to the various organs. Again, we can use it for shock, we can use it to bring the blood pressure up if a patient's hypotensive, and it's typically used in the intensive care unit. So if you have hopes of becoming an ICU or a flight nurse or an emergency room nurse, these are drugs you'll get very familiar with. The next one is one I bet you've heard of, and that's phenylephrine or neosiphrine. This is an alpha adrenergic agonist. It doesn't have much control on the beta receptors. It's mostly just an alpha thing. In this, we can use it either IV or topically. When used IV, it raises the blood pressure, can control certain dysrhythmias, and it's also a vasoconstrictor. So again, an ICU med. However, where you may have used it yourself or heard of it is when used topically as a nasal spray, it decreases nasal congestion. So this is an example how different routes really have different effects. With the topical phenylephrine, it doesn't get absorbed systemically for the most part. It's such a small amount that gets absorbed systemically, I should say, that it won't do a whole lot to the cardiac system. Although you might see when you read, like if you were to read the back of this box, there would be a warning that says might increase blood pressure, heart, blah, blah, blah. So the reason being it might, The likelihood of it is low, but it could potentially. But when you give it IV, it really raises the blood pressure and it really increases the heart rate and it really does a lot of different actions. Now those drugs that we just covered were all from the drug profile in your book. The only other one I'm going to go over right now, and we're going to cover these in depth when we talk about asthmatic medications, is albuterol. Albuterol itself is a short-acting beta-2 agonist, so it's going to, primary indication is going to be bronchodilation. With your beta agonists, we've got short-acting, intermediate-acting, and long-acting. Albuterol is specific to a short-acting beta agonist. So what this drug is going to do is terminate an acute attack of asthma. So if somebody has an asthmatic attack, they feel that it's getting difficult to breathe, they'll grab their albuterol inhaler and take a puff of albuterol, and it'll reverse it. There's a long-acting beta agonist, which patients will take morning and night to help prevent an attack from happening. And again, we'll get into all that when we talk about asthmatic medications. I'm just bringing it up, kind of introducing it now. Side effects of this, tachycardia, jitteriness, and maybe a fine hand tremor are all very common and benign. We're not terribly concerned about it. But then there is a potential it could increase the blood pressure. It's rather unlikely, but again, it could potentially happen. And that's all I have for Chapter 18. I'm also going to cover Chapter 19 now, which is going to be the adrenergic blocking drugs. For your objectives, they're online, but essentially we're just going to flip everything we just did around. So instead of stimulating the sympathetic nervous system, you're going to suppress it. For your objectives, we've already, I think, probably met the functions of the sympathetic nervous system, but we'll touch on it just a little bit. You're going to talk about the various drugs classified as either an alpha blocker or a beta blocker. Talk about the mechanism of action and so forth, and then kind of tell me how you're going to be a safe nurse with this. So if we're flipping the last chapter around, and remember, now instead of stimulating these receptors, we're going to antagonize or we're going to block them. So if you block the alpha-1 receptors within the blood vessels, you suppress that sympathetic nervous system, you're going to result in relaxation or vasodilation. What vasodilation does is it decreases the blood pressure. So some of these medications are used in the treatment of hypertension. Now, for the alpha-1 receptors on the liver, you're going to suppress the release of glucose. What this does is allows your blood sugar to fall too low, so it could cause hypoglycemia. And this is the reason why some of these medications are used cautiously in patients who have diabetes. In the muscles, it's now going to, and this is again the GI muscles, it's going to increase GI motility because it's going to allow those vessels to vasodilate and blood to start flowing back to the small intestines and the large intestine and your bowel. It's not that the blood flow has ever completely stopped, it's just the blood had to be prioritized. So it only had enough blood when the sympathetic system is stimulated to sustain function, but not to really digest anything. It just kept the tissues alive, but didn't allow them to do a whole lot else. For the bladder, instead of it contracting because you're scared of peeing your pants, it's actually going to cause that muscle to relax. What this can be used to treat is for the gotta go right now commercials for the urinary frequency, kind of relaxes that bladder. And then causes the pupils to constrict. Not that that really has a lot of input on your practice, but it is what it does. Alpha-2 we're just not even going to be concerned about right now. Now, slowing down to the beta, or jumping down to the beta. For the heart, when you block the beta-1 cells on the heart, or receptors on the heart, it's going to slow down the force and contractility of that heart. So again, we can use this to treat patients who have tachycardia as a dysrhythmia. Their heart's beating too fast, so we need to slow it down. Maybe you overdose them on epinephrine, didn't monitor them, and now they've got a heart rate in the 200s. We can give them some beta-1 agonists, and it will slow that down. Also, on the kidney, it's going to decrease the release of renin. Remember, when the kidneys are not releasing renin, it helps lower the blood pressure because it's not, renin causes the blood vessel or the body to retain fluid. It's also a vasoconstrictor, so when you stop that, it allows fluid to be excreted, so you lose some blood volume, and it also allows some vasodilation. Now for beta-2, this was the weird one on the blood vessels. Might result in some slight constriction, nothing to be concerned about. For the liver, though, it is, again, going to suppress the release of glucose, so use in caution with asthmatic patients. Now, the lungs is another spot where it becomes a problem. When you block the beta-2 receptors on the lungs, it's going to result in bronchoconstriction. This becomes a problem for your patients with asthma. If you don't have asthma, it's not going to do enough harm, or it's not going to be strong enough to cause harm. It's only in the patients who have a predisposed inkling of having bronchoconstriction, so it's only for your asthmatic patients. And then again, it's going to increase your GI motility because it's allowing more blood to be shunted there. For this chapter, I've got broken to your alpha blockers and your beta blockers. And you'll see with your beta blockers, there's a little bit of an overlap there. But we'll just start with your alpha blockers now. Mechanism of action is going to be an interruption of the stimulation of the sympathetic nervous system. And it can do this one of two ways, and that's illustrated by this little video that we have right here, or this little picture we have here. It can either act by competing with the norepinephrine. So here's your neurotransmitter, norepinephrine. It's going from your presynaptic membrane down to here to tell your body to fire the fight or flight. By giving an antagonist, what it does is it starts to bump that away, and then it binds here. The other way it can do this is, and this isn't irreversible, so it'll bind and then it'll pop up and it'll float around here and it'll bump these and then it'll bind and it'll pop up. The other way it can do it, though, is it can come over to this side of the diagram, and it can bind here and then not let go. And when it binds here, not letting go, it keeps norepinephrine up here and it just kind of wanders around until that MAO or the COMT comes by and breaks it down and gets rid of it. So it works in one of those two ways. Regardless of how it's working, it's going to interrupt the stimulation of the fight or flight response. Focused on the alpha receptors is where we're going to talk about right now. So for the most part, our mechanisms are going to be vasodilation, hypotension, meiosis. Keep in mind that there may be a little bit of a crossover to the beta receptors, but it's not going to be very significant. It'll just be significant enough that when you read the drug outlines, it'll list all your beta receptors as side effects, but understand it's not likely to happen. As it reduces the smooth muscle tone in the bladder and prostate, it's going to stop the urinary frequency, which again is that like Detrol LA is the medication that's on the market. And they've got commercials out with the gotta go right now. One of the commercials is a traffic cop out there, and she keeps giving people the wrong signals because she's gotta pee. And then the other one is for, I think it's a mother and daughter wedding dress shopping. It's really dramatic. She misses the big moment where the daughter chooses the dress because she was in the bathroom. So those are all alpha blockers, and that's how they're working, is they're stopping that frequency. And then also more commonly, they're used to treat benign prostate hyperplasia because it relaxes some of the smooth muscle tone of the prostate gland, so it allows urine to flow easier. Essentially what these do is they all relax the body. So indications, the common ones are going to be hypertension, BPH, which is the benign prostatic hyperplasia or prostate hyperplasia. Pheochromocytoma is actually a tumor of a gland, adrenal gland, and what it does is it causes an increased secretion of norepinephrine. So if we give an alpha blocker, it doesn't stop the secretion of norepinephrine, it just makes that norepinephrine less effective, so it brings down the blood pressure. And then it can also be used for urinary frequency as well. Some of the side effects I want you to be aware of, and again, most of these should make sense if you think about how these medications are working, and some of them are kind of weird. But starting with the first one, they're the first dose phenomenon. This term is simply referring to the first time you give a medication, it's going to be a little bit more effective because the body's not tolerant to it at all, and it's going to cause more severe side effects. Again, it's just the first time you give it. The second and all subsequent administration should not have it. But what you need to be aware of is the first time you push these meds, they might get really dizzy, have a low blood pressure. As their blood pressure lowers, their heart rate might increase. So you'll just really want to monitor the patient after giving them the first dose. This won't happen to everybody, but it happens to enough patients that you need to be aware of it and taking steps to help prevent it as well. Or not prevent it, but keep the patient safe. If they have a low blood pressure and they stand quick, it leads to this orthostatic hypotension, and then they could get dizzy and fall over. So again, keep your patient's safety in mind. Tell them you're going to be dizzy when you first stand. First dose, just the first time they give it. This orthostatic hypotension is really common for patients in the morning, typically not enough to make them pass out. First dose phenomenon will make them pass out. Orthostatic hypotension won't make them pass out, but it'll make them dizzy as they stand. So just think safety. Tell them to stand up slowly, use a side rail, use a bed rail. Just kind of be aware of it. Other side effects include dry mouth, incontinence. Nothing terribly exciting there. Also, just as a note here, I meant to put it on your outline, and you might want to make a note now. I think I make it later, though. You don't want to stop these medications suddenly, any of these blockers, whether it's alpha or beta, because it results in what we call rebound hypertension and then a rebound tachycardia as well. So if somebody takes their medication on a daily basis and they suddenly stop because of cost, or they don't feel like it, or they don't want to, or for whatever reason, it's going to cause that blood pressure to then rebound to a really high level, and it can be really unsafe. So encourage people not to stop it suddenly. That's a really bad idea. It can cause this rebound tachycardia and rebound hypertension. So talking more specifically about the drugs themselves. The first one are just the three that we use for hypertension. Now we're going to talk about these three again when we talk about hypertension, so this is just kind of your bird's eye view as to what they do. You're going to see as I make you write these down, they all end in sin. In fact, they all end in Zosyn, Z-O-S-I-N. That's an easy way for you to identify that these are alpha blockers. So just kind of keep that in mind as you're writing them down. The names, the doxazosine is also known as Carduria. Prazosin is known as Minipress. And terazosin is known as Hytren, or Hytren. On your exams, both names will always appear, so whichever name you learn them by is fine. But make it easy on yourself and know that Zosyn or even azosine are all alpha blockers. A few this and that. It's always an oral medication. We really don't give these IV, although I think some of them do come in IV forms. We don't give them IV very frequently. They've been around for forever. They're one of the first medications used for blood pressure, high blood pressure. And sometimes they'll be used off-label to treat the BPH as well. If a patient can't tolerate the next medication, we're going to talk about the Flomax for whatever reason, we might give them terazosin or prazosin to treat BPH too. Think about the effect and just make sure it's safe to give, and the fact that you really should check the blood pressure before giving this. If they already have a low blood pressure, let's say you check their blood pressure and it's 90/66. You don't want to give this because it's still going to work and still going to make their blood pressure go lower. So instead of having a blood pressure in the 90s/60s, you're probably going to end up with a blood pressure in the 70s or 80s over 30s or 40s. And now we're going to start thinking about pushing some epinephrine to help bring that blood pressure back up. So just keep in mind, if something clinically tells you that it's not safe to give it, don't give it. What you would do in that situation, because again, you don't stop these suddenly, is you would hold the dose and then recheck the blood pressure in a couple hours. If the blood pressures come up, then you could probably give it. If it's not, then you need to probably be calling the physician so that the dose can be adjusted. So just make sure you're keeping patient safety in mind. We don't want that blood pressure getting too low. We certainly don't want it getting too high either, though. It's kind of like the porridge with Goldilocks. We don't want to, not too hot, not too cold. We want it just right. We want the blood pressure just right as well. Okay, the next medication is Flomax. And this really has one use and one use only, and it's to treat BPH. And I always remember the flow makes you go. It makes the flow of the urine go. And then I saw this little advertisement for it. The BPH boys go with the flow. I don't know if that's going to help you remember it or not, but that's all Flomax does, is it increases urination. And only for men, because you have to have a prostate gland for this to work. So if a female were to take this, unless you're somebody who's really special and has a prostate gland, It's not going to help a female go to the bathroom, but it does help men. It treats BPH, and if you don't know, BPH is no FUN, it's no fun, with fun standing for frequency, urgency, and nocturia. What happens is the prostate gland gets bigger. It actually blocks off the flow of urine, so they have to go to the bathroom frequently because they're not emptying their bladder all the time. They get really sudden urges to go because the bladder's telling the patient that it's full and it needs to pee, but then they try to pee and they can't. And they tend to get up a lot in the middle of the night to pee as well. Does this by relaxing the smooth muscle, improves the urinary flow, and it takes about 7 days for it to be effective. So it's certainly not an overnight treatment, but it's relatively quick. The alternative to Flomax is actually a chemotherapeutic agent, which reduces the size of the prostate gland, and that takes 3 months to work. So when you compare it to Proscars, that medication, it's really quite quick, 3 months versus 7 days. But again, it's kind of a long time if you have to pee. So those are your alpha blockers. Now we're going to talk about the beta blockers, and this is a term you're going to get really comfortable with because as you go through not only this class but all your med-surg courses, your critical care courses, beta blockers are going to be used all over the place. They're really popular and they're a pretty good medication to have on board. What they do is they still block the sympathetic nervous system, but they're going to be more specific to the beta receptors than the alpha receptors. Now you're going to see certain ones will work a little bit on the alpha receptors as well. And I'm going to show you an easy way to identify if it's working solely on beta or if it's both a beta and an alpha adrenergic antagonist. As far as what these do is they compete with norepinephrine and epinephrine, which are your neurotransmitters to fire the fight or flight. So by competing with them, it reduces the fight or flight impulse of the body. Again, they can be selective or non-selective. If they're selective, they're only working on beta 1. If they're non-selective, they're working on beta 1 and 2. And they might also block alpha receptors. We'll come back to that point. When you're trying to think of what they do, think about the location again of the receptor. Based on the location is going to tell you what that medication does. So if you can remember which receptor that medication is acting on, you should be able to understand most of the side effects and the indications for it. Your indications are going to be cardiovascular largely in nature. One, they can be used for chest pain or angina. Angina is simply a warning mechanism that as blood flow decreases to the heart, it sends out the pain, and typically the pain goes down the left arm. It's a chest pain people complain about. Angina is not the same thing as a heart attack or a myocardial infarction. Angina is just a warning that the heart's starting to be stressed and not get enough blood. If angina is not fixed, then it can escalate into a myocardial infarction, which means blood flow is actually compromised or not flowing to the heart. Beta blockers help prevent this by slowing down the demands of the heart. As you get more relaxed, you need less oxygen. So that helps ease the pain and it takes some of the stress off the heart. It also inhibits the stimulation by circulating catecholamines as well, which reduces the stress on the heart too. Beta blockers can be used for certain dysrhythmias, and what it does is it just slows down the conduction system of the heart, and we'll talk a little bit more about that later. And then their main use is probably going to be for hypertension. Beta blockers reduce the stimulation of the sympathetic nervous system, which reduces the fight or flight response, lowers the heart rate, causes vasodilation, and it brings down the blood pressure. These are one of our first-line antihypertensive medications. So we're talking about them now, and we're going to talk about them again when we hit high blood pressure. All the medications that we cover from here on out can be used for blood pressure, and then some of them have other mechanisms they can be used for as well. The last indication, the reason why it has an asterisk there is this is kind of a double-edged sword. The indication is heart failure. And for this, you need to understand that only certain beta blockers can be used for this condition. Certain beta blockers can be used for it and help it, and others actually make the condition worse. So when I say this one can be used for heart failure, don't blanket that to everything. It's only certain beta blockers. And I'll again show you a couple of easy ways to remember which ones, well, easy ways for me or how I remember which ones can be used for heart failure. Otherwise, heart failure actually turns into a contradiction of beta block usage. So it's kind of a weird thing. Some of the adverse effects, I've got this categorized physical, and then who I want you to use cautiously, and then some considerations I want you to be aware of. Since we're lowering the blood pressure and the heart rate, your first two side effects are going to be hypotension and bradycardia. Again, if the blood pressure is low, don't give it. If you've got a blood pressure that's less than 100, you should not, the top number, systolic number being less than 100, you should not give a beta blocker. That's not very responsible. Similarly, if the heart rate is low and you give a beta blocker, it's going to lower it even further. So you're not going to give a beta blocker if the heart rate's in the 50s. Unless you have explicit instructions from a physician to do so, you're not going to do that. That would not be very responsible of you. Also, because it's inhibiting norepinephrine within the system, going to cause a little bit of lethargy and fatigue. These patients will often get started on a blood pressure on a beta blocker, and their blood pressure comes down, their heart rate comes down. That's great, but they'll come into the office and they'll tell you that they just have zero energy. That's because it's also working on the norepinephrine. Certain ones are worse than others for doing this, but they all certainly have that effect. For this reason, normally we give it in the morning because, one, your blood pressure naturally rises in the morning and relaxes in the evening, but also it takes, like, you typically see the lethargy kick in about 8 hours after you give the medication. So if you give it towards the morning, then hopefully it's late afternoon to early evening when you start getting tired, and then it can actually help you sleep as well. But it will cause that lethargy and fatigue. The next one is hypoglycemia, and this is kind of a two-edged sword. One, it prevents the release of glucose from the liver. So if your blood sugar falls low, it kind of inhibits the mechanism that your body normally uses to bring your blood sugar back up. The other double whammy with beta blockers is it masks the early signs and symptoms of hypoglycemia. When you learn about diabetes and hypoglycemia, you're going to learn that when your blood sugar falls low, your heart beats up, you get kind of sweaty. All those clinical manifestations are very sympathetic in nature. So if you're taking a beta blocker, which suppresses the sympathetic nervous system, your blood sugar is going to fall low and you're not going to pick up on the early signs and symptoms of it. So it's used very cautiously in patients who are diabetic as well. Any medication that's used for blood pressure is going to cause sexual dysfunction. Again, this will sometimes cause people to quit using it, similar to the antidepressant medications. Something to educate your patients on. It's worse for the men than it is the women, but we certainly don't want somebody to suddenly stop their blood pressure medication because it's interfering with their love life as well. And then last on your physical effects is it can cause bronchospasm. With the bronchospasm, it's only going to happen to patients who have asthma. So we use these. It's not that they won't never, ever, ever be used, but they're used with extreme caution in people who are asthmatic as well. So just to recap, these medications are used cautiously. It's not that they're never used, but they're used cautiously in patients who are diabetic, and that is both diabetes 1 and 2. They're used cautiously in patients who are asthmatic and also people who have COPD. And then they're used with caution in patients who have heart failure. Because it actually decreases contractility of the heart, it can make heart failure worse. A couple of your considerations: make sure you're checking blood pressure and pulse. If it's low, don't give it. Typically, we give it in the morning. Educate on the side effects. Now, I told you that there's an easy way to identify if these were selective or if they were less selective and acting on more receptors. These beta blockers, they all end in LOL. But if they end in the OLOL, it's a cardioselective. The OLOL are going to have very, very little effect on your adrenergic alpha receptors. They're going to be more selective to the beta receptors. Now, the ones which just ended LOL, they're laughing out loud, are less selective. So they're hitting alpha receptors and they're hitting beta receptors. So they're going to have more side effects, more indications, and be a less specific medication. Just kind of as an easy way to identify them as we go through. Jumping into the drugs. So the first one we have is atenolol. Now atenolol you can see is an OLOL. So this is going to be more on the beta cells unless it's not going to have much effect at all on the alpha cells. This medication was developed to treat hypertension and it can also be used to help relieve angina, so the chest pain. It can also be given after somebody's had a heart attack to help reduce the stress on the heart. Now, new research on this, and actually I read this article last summer, so the summer of 2014. Research has shown that this is really good at reducing peripheral blood pressure. So you'll give this and you'll check the blood pressure in the arm and the pressure is going to be low. So you'll think that your medication did its job. It's brought the blood pressure down and you'll go on about your day. What they're finding though is although it lowers the blood pressure in the arms and legs peripherally, it fails to affect the central blood pressure. So the blood pressure of the arterioles going towards your brain, heart, kidneys, the organs which are truly affected by high blood pressure, it really doesn't affect those vessels as much. For that reason, although you're still going to see this in clinicals because this is kind of new study, I anticipate or I predict these are probably going to fall off the market probably by the time you guys start getting out into practice. Atenolol is not going to be used as frequently as it is now. Again, it's just not as effective in lowering blood pressure where it needs to be as we once thought it is. Regardless, though, we'll talk about now because we still use it. And yeah, it's good. It's used for blood pressure. It's not good for blood pressure, but it's used for blood pressure. Make sure you're checking the blood pressure before you give it. It can be given IV or it can be given as an oral therapy for maintenance therapy. Now the next one is carvedilol or Coreg. Carvedilol, now you're going to see, is just an LOL. So this is a non-selective beta blocker. It's working on 1 and 2, plus it's also working on the alpha-1 antagonist. Because it's non-selective and it's an alpha-1 guy, it can be used for the treatment of heart failure. How I remember that carvedilol is one that can be used for heart failure is because it's going to carve down the large heart. I have a picture right here. Your normal heart is on the left with heart failure on the right, and you can see how the ventricles get kind of big with the one on the heart failure. Although this isn't how it works, this is just how I remember. It's going to carve this heart back down to size, so it can be used for heart failure. Carvedilol carving down the heart can be used for heart failure, is your takeaway point there. It can also be used for hypertension and angina. This is an oral-only medication, so it only comes via a pill. It can come in a regular release, so just a normal tablet, or it can also be used as a controlled release tablet. The next one I have is labetalol or Normodyne, and again, you're going to notice it's an LOL medication. Because it's LOL only, it's working on beta and alpha receptors. This medication isn't used frequently for maintenance therapy unless blood pressure is not controlled by other means. What we use this medication for is the treatment of severe hypertension and then hypertensive emergencies. And the blood pressure greater than 200/100, I think it might actually be 210/110 for a true hypertensive emergency. Regardless though, it's a high blood pressure. Brings that down wonderful. We'll use it like in the pre-op or in the post-operative unit. If patients have a high blood pressure after surgery, we frequently will use labetalol to bring down that blood pressure. One of the side effects of many anesthesia agents is that it increases the blood pressure, so this is a good medication for that as well. But it's old, it's kind of tired. We only use it when our other agents really aren't going to work. You're not going to see it used in a pill form very frequently, but again, if somebody comes in with a high blood pressure, we're going to get an IV started and we're going to give them this IV. With this though, it acts very quickly, so make sure when you push this, your patient's either sitting down or optimally laying down, because as the blood pressure falls, the patient's going to get dizzy. And as they get dizzy, they do run the risk of passing out. And we don't want to be pushing this and then have your patient pass out and fall and hit their head. If they're laying down, they pass out, it's probably okay. But if they have a ways to go after they pass out, that becomes a problem. So just keep in mind, it's best if they're laying down for this medication. Our next one is Lopressor or metoprolol. This is probably the most common beta blocker around, so make sure you know it, because it doesn't matter where you work, you're going to have to know this guy. Indications very, very commonly used for after an MI to reduce the stress on the heart, brings down blood pressure like a charm, and then people also use this off-label to control anxiety, particularly stage fright. What it does is you take it, it does suppress the sympathetic nervous system, so then patients don't get quite as nervous. So if you have to give a speech and you know you have a fear of speaking in front of people, you can take Lopressor before and it'll help you control that fear while you give your speech. So kind of a weird thing about that. Also, Lopressor can be used in heart failure, but it can only be used if it comes in the XL form. So you'll see it'll be Lopressor XL or metoprolol XL, and that's the extended release form or extended length form. And I remember this one being a heart failure medication by the XL for an extra large heart. Again, it's not that it makes the heart any smaller, it just makes it a more efficient pump, but it is approved for the treatment of heart failure. Ralta can be given orally or IV. Now with this, with all IV medications, you push them slow. But for metoprolol specifically, you're only going to give 1 milligram per minute. And a typical dose of metoprolol is 5 milligrams. So you really will stand there for 5 minutes pushing this medication very slow. If you push it too fast, you'll bottom out their blood pressure, so their blood pressure will fall really low, and you're also going to cause their heart rate to slow way down, and that's not good either. So make sure that you are being smart about how fast you push these medications, and you push them slow. So turn on something on the TV that you can kind of watch or visit with your patient, because you're going to be there a few minutes. And then the last one's propranolol. This is such an old, tired medication, but it's still on the market. It does a good job at what it's supposed to do with the hypertension, and it controls certain dysrhythmias. It can also be used for that pheochromocytoma, the hypertension associated with that tumor, but it's old. We don't use it so frequently anymore. It is an OLOL, so it's only working on the beta blockers. It's not affecting the alpha, or if it affects it at all, it's very minimally, and it just suppresses the sympathetic nervous system. Check your blood pressure before you give it, and there's not much else, and your pulse before you give it. Otherwise, there's not much else to know about propranolol besides the fact that it exists.